The Symbicort Turbuhaler has been used to help control the symptoms of asthma and improve lung function. Symbicort is known for its clinically effective drug delivery, ease of use, lung deposition, and low flow rate. It has proven efficacy in asthma, COPD, and patients suffering from acute asthma attacks. The unique design of the mouthpiece ensures efficient drug delivery of fine particles. The ideal size for optimal drug deposition is 1.5 to 5 micrometers. Symbicort Turbuhaler delivers a fine particle fraction of 45 to 50% for budesonide and 40 to 45% for formoterol. Thus, Symbicort Turbuhaler ensures optimum drug delivery into the lungs where it matters. Let's now understand the cause of asthma and COPD. Both are chronic airway diseases caused by inflammation. This inflammation is caused by the release of mediators such as mast cells, macrophages, eosinophils, and T lymphocytes, which can result in hyperresponsiveness, bronchoconstriction, hypersecretions, and the formation of mucus plug. An effective anti-inflammatory treatment is inhaled corticosteroids or ICS, such as budesonide, which targets the glucocorticoid receptors in the epithelial cells to reduce inflammation. However, the location where ICS exerts its anti-inflammatory effect matters. A stronger anti-inflammatory effect on the airway surface liquid can suppress the innate immune network and increase the risk of infections such as lower respiratory tract infection, non-tuberculous mycobacterial infection, and pneumonia. Ideal ICS should provide patients with the right balance between efficacy and safety. Different ICS have different safety and efficacy outcomes and how they affect the immune system. Every ICS has a unique molecular structure which determines its lipophilic characteristics, affecting the rate of absorption and clearance. For example, budesonide is more hydrophilic due to the presence of the hydroxymethyl group at carbon 21, while fluticasone is more lipophilic. Budesonide can cross airway surface liquid in about 6 minutes on average, compared to fluticasone, which may take up to 8 hours. Thus, budesonide is absorbed more quickly into the epithelial cells. Because fluticasone stays longer on the airway surface liquid, it may be associated with an increased risk of pneumonia and other infections. Recent studies show that budesonide is associated with lower risk of non-tuberculous mycobacteria in asthma patients. A Cochrane review also reveals that budesonide-formoterol combination reduces the risk of pneumonia compared to fluticasone-salmeterol combination. Study by Suissa concludes that the pneumonia risk is dependent on the type of ICS rather than the dose of ICS. Exacerbations can be induced by inflammation and infection. In the management of asthma and COPD, it is important to reduce incidence of exacerbations. Budesonide is associated with a lower risk of immunosuppression and infection compared to fluticasone. A unique property of budesonide is its ability to form reversible bonds with fatty acids in the airway cells through a process called Esterification. As the concentration of budesonide decreases, the esters are hydrolyzed back to their active state, binding again to the glucocorticoid receptors to reduce inflammation. The budesonide esters can be retained for up to 43 hours in the epithelial cells, thus prolonging its anti-inflammatory action in the lungs, leading to better efficacy outcomes. Compared to other treatments, SMART approach has consistently reduced the rate of exacerbation compared to medium and high doses of fluticasone-salmeterol combination. Pharmacokinetic and pharmacodynamic properties of budesonide, fluticasone, and beclomethasone are distinct, and these differences may lead to different therapeutic outcomes. Systemic potency of ICS is influenced by many parameters such as lipophilicity, volume of distribution, elimination half-life, and receptor binding potency. The systemic potency of budesonide is low as compared to fluticasone and beclomethasone. These properties ensure budesonide has minimal buildup of tissue steroid levels. As compared to budesonide, fluticasone has a volume of distribution approximately double that of budesonide, twofold greater receptor binding affinity, and fivefold greater half-life. The clearance rate of beclomethasone is fast. However, unlike budesonide, it is not able to form esters. Thus, beclomethasone may not provide prolonged anti-inflammatory effect. Budesonide was shown to have better safety profiles compared to other ICSs across different patient groups. It is associated with lower short-term growth impairment in children, possesses lower risk to pregnant women, and not associated with increase in bone fractures versus placebo in patients with COPD. Hence, not all ICSs are the same. The ideal ICS have a balance between efficacy and safety.